Dr. Lee is originally from Ann Arbor, Michigan, where he graduated from the University of Michigan with a Bachelor's of Science in Movement Science. He received his Doctor of Dental Surgery from the University of Michigan. Upon the completion of dental school, he was trained at the University of Illinois, Chicago Advanced Prosthodontics program, receiving a certificate and master's degree in oral science. Dr. Lee has been in academia since 2007 and is currently the director of the Advanced Education in Prosthodontics program at the Ohio State University College of Dentistry. He also maintains a prosthetic practice at OSU Dental Faculty Practice. Welcome, Dr. Lee.
Thank you so much for the kind invitation. I'd like to thank Dr. Ying and Sharon for inviting me to share this time with you. And thank you, Dr. Foster and Dr. Kramer, for setting us up for this wonderful presentation. I'd like to share my screen so we can get going. Let's see here. Okay, can everyone see my screen? Can you hear me okay? All right. So as Sharon said, I am in the prosthetics. So prosthodontics is the specialty in dentistry that specializes in replacing teeth. So we treat a lot of patients that are missing teeth, and along with other specialty, we work together to replace teeth for people that are either missing teeth because they had them taken out for various reasons, or people that are born without teeth, or in this case, people that have lost teeth early. So this was my first time to be introduced to HPP and being involved in this organization. But I do remember Dr. Kramer, when she was a resident orthodontics, she brought this question up and said, "Do you know anything about HPP and how we treat those people in our clinics?" And I at that time, I didn't really know much about HPP, but as I start connecting some of the dots, I realized that we were already treating some of HPP patient in our graduate clinic already. So I feel very fortunate to be associated with this group, and I look forward to getting involved even further as time goes on. So let me see. Okay. So as we talked about before, some of the oral manifestation we see with HPP are the early loss of teeth, but also the lack of cementum and the poor quality of it. Enamel hypoplasia, I saw one of those questions come up, and how they may in fact influence our teeth development, and also trying to keep them healthy over long period as they grow into adulthood. And also these can then influence the eruption of the permanent teeth, as well as having some defense mechanism towards having decay in the mouth. And also that can be influenced because of enlarged pulp cavity and root canals that may be associated with HPP as well. Some of the dentin formation, as Dr. Foster talked about, the quality of the dentin may be more of an issue, and we'll talk a little bit more about that later. But it really is, for me as a prosthodontist, is going to be the increased mobility and possibly the early loss of these permanent teeth. So we're going to focus a little bit more on that. We kind of talked about dental decay and how some of the protective mechanism for cavities to progress and so forth. Dr. Foster mentioned about how it can repair itself, but as an insult to the teeth and cells, when you have decay and how the progression of decay happens, it starts to demineralize the surface of the teeth, and then it progresses into softening up all the teeth, including enamel and dentin. So then how this can influence some of our patients then is going to be the calcification of dentin and how well it can withstand the insults from decay itself. But also at the same time, for me as a restorative dentist, and it's going to be, can we replace those missing structure with restorative material? And we rely a lot on the bonding itself. So the quality of the dentin is different than can we etch it properly? Can we apply bonding agents properly? And will they stay on for a good amount of time? Tooth color filling versus silver color filling, those are always discussions that we have. Completely different mechanism of how they stay on. But when the dentin is more affected, then I would think that the tooth color filling is more affected, where you rely on the bonding itself to have good prolonged retention. So, you may be choosing different material that may be of different nature when you are talking about bonding itself. There's some external resorption that have been associated with HPP. And also we talked about enlarged pulp chambers and canals. And then this might be where you see more patients that will need root canals and so forth because of the larger pulp chamber. So they may be prone to getting toothaches more than some other people. When we talk about bone loss itself, we talk about how the periodontal ligament is involved and how this may be more susceptible to bacterial invasion, which can then lead to increased chances of periodontitis, which is a progressive bone loss around the gum tissue. Periodontium is a fancy term for what we call the gums, the bone, and the teeth, all three of them together. So then how do we replace missing teeth? When we have early tooth loss, and especially if they are still growing, then we may be providing them with different kinds of mechanisms to replace missing teeth. And easiest for them might be that they're wearing something that comes in and out, something that can be pretty easily replaced. And also as they're growing, you can refit them or you can just replace them pretty easily. And then as they go into, after orthodontic treatments are done, but they're still waiting to become adults to get dental implants, we may be using crown and bridges short term to have these restorations. And then as they grow into adulthood, these missing teeth can be replaced with dental implants as well. And as I was doing my search for literature on dental implants and so forth with HPP patients, really only thing I can find was case reports as well. So through some of the long-term study that we can generate at OSU, hopefully those will be good long-term clinical studies that can provide better evidence for our patients as well. Removal of partial dentures, these are some of the things that you may have seen for a long time. Maybe you have relatives, other people that are using these. These are great because they can replace multiple missing teeth at one time. These shiny metal clasps may not be as the most aesthetic, obviously. However, depending on where it's placed, they can be very retentive. They do engage some of the underguts that are naturally provided by our teeth, and the clasp engage those. The retentive forces that come from the clasp itself is offset by actually the periodontal ligament that Dr. Foster talked about. And these then attach to the cementum of the teeth, right? But if we have patients that are affected by lack of cementum or the development of cementum and how that was attached to the ligament themselves, then maybe over a long period of time, they're not the best supporting prosthetics overall, because they may already have mobile teeth to start, and then using the removable partial denture for a long period of time can actually increase the incidence of having mobile teeth. So some of these type of horizontal forces that get put on the teeth then can maybe contribute to increased mobility of the teeth long term. So we do have to look at them long term and see how these can influence their outcomes as well. And again, this is all dependent on how strong their teeth are in the periodontium, how stable they are in the gums, and how they can then support the partial denture for a long period of time. About that. Okay, so the next type of prosthesis is what we call a bridge or a fixed partial denture. As you can see here, it will replace a missing tooth by crowning the teeth on the neighboring side and then joining them together from one side to another, what we call a bridge. Because our HPP patients may have a large pulp chamber, then we do really need to be mindful of how much tooth structure we reduce. to prepare these bridges. And of course, that depends on how much of the tooth is already destroyed by cavities and so forth. But because of our technology, we can actually prepare things very minimally, but also still have very strong materials. One of the materials that I use quite often nowadays to have minimal preparation is zirconia. So zirconia we use quite often in dentistry now, and it can be thin, but also be very, very strong as well. So maybe for HPP patients, we can use certain material to minimize the tooth loss, but also give them something aesthetic as well. But also with our HPP patients, it may be the same condition with the RPD patients, where we need to look at how well the teeth are supported to start. So if they're immobile and we're preparing a bridge, then it may not last as long because they're already mobile to start. And if our patients are more susceptible to recurrent decay, then we do need to look at them more often and also provide some form of fluoride treatment for those patients as well, and maybe increased number of recall visits. And lastly, depending on how many teeth they're missing, the span of the bridge. So these 3-unit bridge can turn into 4-unit, 5-unit, and then might become a really long span bridge. And then last modality I will talk about is implants. And you can see here, the implant itself needs to be embedded in a good amount of bone. You can see here, we need at least 1 millimeter of bone from the front side to the back side of it. And then it needs to be away from each other as well. If they're too close to each other, then the bone doesn't heal very well. One thing nice about HPP patient is that they do seem to have a regular eruption pattern, which is promising because when you have permanent dentition, that means the bone is present. There's some other group of children that we do see that are born without adult teeth, and those patients don't have the bone. But for HPP patient, it seems like we do have regular eruption pattern. So then, which then tells us that adult teeth may still be present, they may be mobile, yes, and you might lose them early, but the bone will be there. Only thing that we don't know necessarily is how good is that bone quality. A lot of the times, the bone that the length of the implant that we use is about 10 millimeters, but also, we do utilize a little bit shorter implant, which is different from a narrow diameter implant. So there's a big difference there. Like mini implants, those are pretty common, but you do hear about those versus a standard size implant. And as well as, we do get this question a lot, how soon can they get dental implants? And this really depends on girl or boy. Girls mature much faster than the boys in every way, shape, or form. And if they're teenagers and they're still growing, what we see is that if the implants are placed too early, then the rest of the teeth and the face still grows, but the implant itself doesn't move, which means it looks as if the tooth gets stuck in the mouth. We call that ankylosis, but it appears as if that happened. So every teeth becomes a little bit longer, but the implant stays where it is. So usually it'll need a revision for sure if it's placed too early. A second thing really is how good is the quality around the implant itself, and for a long period of time can it be used. So this was a case study that was actually published very recently in 2021, and it was actually quite serendipitous because as I was preparing this lecture, it actually was published that month. So I was very happy to see this. But this was a 7-year follow-up for a patient that was utilizing dental implants for having premature tooth loss for this patient. And you can see here, the patient has a lot of bone loss here. You can see that the bone only comes up to half of this tooth. Usually bone will be up here for majority of the patients, but also at the same time, you can see that this patient was using dental implants as a transitional type of method as this person navigated through losing the teeth. So based on the bone loss and the mobility, my guess is that they were losing a lot of bone, but because of HPP and seeing how implants survive in the mouth, they were taking their time and transitioning this patient through their care. And then at the end, this is what the patient received. These are implant bridges. You can see a good number of implants here and how it's supporting the mouth overall. And then how this can look in the mouth as well. This is what it looked like when it was done. So a lot of prosthetics here, and hopefully for a long period of time, patient can utilize something like this. So what we don't know really is how long will implants survive in the mouth? How good is the mineralization around the dental tissues? Implant itself, it's not always the quality of the quantity of the bone, but the quality itself over a long period of time, because when we put these implants in, we're literally, making a hole in the bone, but also in the threads, new bone has to form, right? And those new bone that's forming and integrating with the implant then provides stability, not just for that immediate placement, but also for a long period of time as well. And those type of things can then hopefully holds up to what we do with our mouth and have all the food that we eat and chew. And it needs to be able to withstand all of the forces that we generate as well. Some of the repercussion of not having good bone quality in implants is what we call dehiscence or fenestration, where we start to see bone loss and the thinning of certain bone, especially on the cheek side or the front side by the lip, and what we call dehiscence, where we start to see the bone starting to lose a little bit and then the implant showing through. So for this type of patient, we would emphasize on monitoring their dental care and seeing their oral care provider more often than that. So again, bone maintenance, on a normal patient, we would see maybe 0.1 millimeter loss per year, which is very tiny amount, but would this be the same for HPP patients? We don't know yet. For some of the protocols that was described, they discussed maybe having the implants submerged for a 6-month period of time. Normally at the College of Dentistry here, we wait about 4 months healing, but we would have a little bit more healing period for HPP patients and also some delayed loading protocol as well. But again, as I mentioned, we only have clinical reports that are available at this time for our evidence. So what we're hoping is that we can have longer term follow-ups and then an outcome as needed. And lastly, for implants, it's the cost. Unfortunately, implants are not cheap, especially the number of missing teeth that people may have, and replacing that are replacement and so forth are not necessarily very affordable for certain people. Hopefully, if they're missing only a few teeth over a long period of time, they can invest in it and then use it for a long, long time. Fortunately, more and more dental implant companies are paying towards replacing some implants as well. So that's something that patients need to check with their insurance provider and see if implants are covered in their plans.